This was a previously healthy young man who, in March of 2014, began to develop some epigastric pain and anorexia and about a 10-pound weight loss, and went to his GP, and they started him on some PPIs that didn't really have much effect. He had some imaging studies that revealed a 6-centimeter jejunal mass and enlarged mesenteric lymph nodes. He had, at that point, a biopsy, which was non-informative, and so he came to resection. This was an outside case. I don't have any of the materials, but there was a main 6-centimeter mass and then 2 separate 1-centimeter nodules and then some enlarged mesenteric lymph nodes. And I have a few sections from this case. This was a transmural infiltrate that strikingly involved the mucosa, but went all the way through and perforated, composed of medium-sized to large cells with ample cytoplasm, oval nuclei, prominent nucleoli, some mitotic activity. Sort of a monotonous-looking infiltrate, and the lymph nodes were involved by this process. And immunostains were performed, and showed, so this infiltrate involved both the entire bowel wall and then sort of tracked along the mucosal surface, and that's what the immunostains are evaluating. So these this lesion, lesional cells were CD3 and CD7 brightly positive, CD8 positive, and CD56 positive, and that combination, that phenotypic combination, in addition with the remaining findings, so these cells were stained for some cytotoxic markers, a brisk proliferative index. Cells were negative for CD5, CD4, CD57, CD30, EBER, and B-cell markers. And then this lesion recurred several times, and there were some additional stains done later, and it showed also that lesional cells were negative for TCR beta and for gamma as well. And flow cytometry was negative. So the combination of these findings, the morphology and the phenotype, is most compatible with this lesion, MEDL, or monomorphic epitheliotropic intestinal T-cell lymphoma. This used to be called type 2 enteropathy-associated T-cell lymphoma. And I just want to start with a quick rundown of the intestinal T-cell lymphoma. So the GI tract is a fairly common site of involvement by lymphoma. The majority of those are of B-cell origin. About 10 to 15% are of T or NK origin, which sort of mirrors the distribution of B and T-cell lymphomas elsewhere. Primary intestinal T-cell lymphomas are uncommon, and in the West, 2/3 of these are enteropathy associated. So these are people who have a history of celiac disease or who have silent celiac disease and develop this very aggressive lymphoma that arises in that setting. MEDL was formerly known as type 2 enteropathy-associated T-cell lymphoma, and therein arose a great deal of confusion because, in fact, this lesion isn't really related to celiac disease. This is a fairly common lesion among primary intestinal T-cell lymphomas in Asia. Given the lack of the haplotypes that are associated with celiac disease in most Asians, this is the EDL, the enteropathy-associated lesion, is very uncommon in Asia. So the commonalities between these two lesions are that they're epitheliotropic, sometimes strikingly so. They're T-cell lymphomas, so they're clonal lesions of T-cells, and they're really aggressive. There are a couple of other lesions that arise as primary in the GI tract of T-cell type. One is this lesion, intestinal T-cell lymphoma, NOS. That's a T-cell lymphoma that doesn't meet criteria for either EATL or MEDL. And that's essentially a wastebasket. There's not a lot of those cases. There's not a lot of features that sort of are uniform among that group. And then there's this rare lesion of this indolent process that's restricted mainly to the mucosa, which we don't really ever see, but and it's now included as a provisional entity in the most recent WHO classification. But the bulk of the lesions that one encounters that are primary to the GI tract that are of T-cell origin are these two lesions. So the main clinical features for Needle is a slight male predominance. There's no association with celiac disease. It typically arises in the small bowel, most frequently in the jejunum. Mesenteric node involvement is common, and these lesions are aggressive and can disseminate widely. Patients typically present with abdominal pain, plus or minus obstruction or perforation. And there's no history of malabsorptive symptoms, which is because of this. And again, these are aggressive with a median course of 7 months. The pathology, these are monomorphic, and that's part of where it gets its name from, and that's really in contrast to those that arise in the setting of celiac disease. So these are large kind of cells, but they're monotonous. And the general principle is that in the lesions that arise in the context of celiac disease, there's more pleomorphism. That doesn't mean that between patients there can't be some variation in the cell size. So there are some people who present with a larger cell lesion, which this patient had, and then some who present with somewhat smaller cells. But in general, they're monotonous, and most cells look like the remaining cells. There's not a lot of necrosis. There's not a lot of inflammation. This stands in contrast to what one sees in the enteropathy-associated lesion. And there's striking epitheliotropism with this lateral spread of neoplastic cells along the mucosa. And what that means for these patients is when they have their lesion resected and then are treated, first of all, these lesions disseminate widely, but secondly, they recur locally. It's very hard to really extirpate this process. And one sees a villous expansion, which we saw in our case, which I don't have good photos of, but no atrophy. In other words, tumor cells infiltrate the submucosa and actually go infiltrate the mucosa and go into the epithelium. But there's no intraepithelial pre-existing lymphocyte pool, which is what gives rise to the lesions that one sees in EATL. The phenotype is classic and importantly is different from that which one sees in enteropathy-associated lesions. So these are CD8 and CD57 positive. They express some cytotoxic markers. And interestingly, these are more frequently gamma delta T-cell origin than of alpha beta T-cell origin. That doesn't mean that there aren't some lesions that are derived from alpha beta T-cells, but the majority are derived from gamma delta T-cells. And then there are occasional cases that lack either marker, and that was our situation. Interestingly, about 20% of these express CD20. And then there's this megakaryocyte-associated tyrosine kinase, which is uniformly positive in these lesions, and is supposed to be one of the distinguishing features between this and enteropathy-associated T-cell lymphoma. This isn't a marker that I'm aware that anybody carries, but it's popular in the description of this lesion. The T-cell receptor is always rearranged. There are cytogenetic lesions that are fairly common in this disease, but that don't really distinguish this from enteropathy-associated T-cell lymphoma. But one thing that is interesting is that these lesions more typically harbor gains of MYC. There were a bunch of other stains that were done that I didn't mention. One of them was MYC, which was negative in our case. So I don't know if this amplification was present in our case or not. And then there are recurrent mutations in the JAK-STAT pathway, which is not unique to this T-cell lesion, as seen across a broad spectrum of T-cell neoplasia. Just to compare enteropathy-associated T-cell lymphoma that arises in the context of celiac disease and our lesion, these are more common in Northern Europeans because of this genetic predisposition. The morphology is polymorphous, so there's more variation between individual cells in a given lesion. There's a fair amount of inflammation and necrosis, so morphologically these can be confused for another lesion that commonly involves the GI tract, which is the extranodal nasal type NKT cell lesion. Those are also associated with extensive necrosis. But what one sees in these lesions frequently, though not always, is morphologic evidence of celiac disease in areas of bowel away from the main tumor mass. And if you don't see that, one will find evidence of serologic evidence of a predisposition to celiac disease or the right haplotype. And the immunophenotype is different. These are typically CD4 and CD8 and CD56 negative, which is not what one sees in our lesion. And some of these become, as they become more aggressive, CD30 positive, which raises in the differential diagnosis then other CD30 positive lymphomas. And these are more typically alpha beta than gamma delta positive, and they rise, as we said, in the small bowel. And by contrast, the lesion that I just discussed is more common in Asians. There's no association with celiac disease. These are more commonly monomorphic, although that can be a little bit subjective. There's less inflammation and necrosis. These are, importantly, CD8 and CD56 positive, and more commonly gamma delta positive. And the differential diagnosis for this lesion includes anaplastic large cell lymphoma, which, as you know, is CD30 positive, but that lesion is very brightly and uniformly CD30 positive when one sees CD30 positive cells. In cases of EATL and also occasionally MEDL, there's less uniform expression of that. The hallmark cells of ALCL are not something that you see in these primary GI tract lymphoma, T-cell lymphomas. Extranodal NK T-cell lymphomas are, importantly, EBER positive. So whenever you get a T-cell lesion in the GI tract, it's important to do an EBER stain to exclude that entity. Peripheral T-cell lymphoma, NOS, can involve the GI tract. Generally, there you lose some of the panty-antigens that were retained here, like CD3, and there's generally evidence of systemic disease. And then finally, you have to exclude a B-cell lymphoma, which is so much more common in the GI tract, but that's not hard. And the clinical course in our patient, his original diagnosis was in June of 2014. He initiated chemotherapy and an auto transplant. He had a rocky course, but eventually went into remission. But about a year later, there was no evidence of disease, but shortly thereafter, he was noted to have 10 centimeter anterior mediastinal mass, bowel wall thickening, and multiple retroperitoneal masses. And by November that year, he was dead. So these are aggressive lesions. They're very difficult to deal with. And that's it.